I would like to thank the organizers for inviting me to join this session. The importance of non-communicable diseases among those living with HIV only grows as the population ages. As multiple studies have demonstrated over the past few years, we are seeing better and better life expectancy numbers as people start antiretroviral therapy sooner and achieve immune recovery and virologic suppression. A meta-analysis of these studies showed that having a low CD4 at ART start is the most important predictor of lower life expectancy. But we can see that people are living much longer now. If treatment expansion continues at current rates, more people will age into and beyond the 5th decade of life. In sub-Saharan Africa in 2011, about 1 in 7 were already 50 or older. In 2040, that number is projected to be 1 in 4 and will total over 9 million people. In South Africa, which has the largest number of people with HIV and on treatment in the world, the overall prevalence of those over 50 will be 17%. These data are from the IDEA Southern Africa cohort and provide a more specific look at the South African population. Investigators examined data from patients in 6 large clinics, where patient enrollment went from 5,000 to 10,000 between 2004 and 2012. Over that time period, the percentage of those 50 and older at enrollment went from 6 to 10%, and the percentage of those 50 and older in care went from 2 to 20%. In a comparison with local mortality estimates, the 5-year cumulative mortality hazard is shown here to disproportionately increase over time among those with HIV compared to those without HIV. So not only are we seeing older patients in our clinics, but we are seeing more mortality in this age group as well. Studies in Western cohorts illustrate how HIV and ART modify the risk of NCDs. Although there remains some controversy about how HIV affects the speed and complications of aging, we can agree that the causes of death are increasingly related to chronic disease outcomes and non-AIDS defining events. In the Veterans Aging Cohort Study, or VAX, those living with HIV had significant increases in the incidence of heart attacks, end-stage renal disease, and AIDS-related cancers. There are many reasons for why people with HIV may have increased risk of these serious non-AIDS outcomes, and this slide provides one schematic of the role of inflammation and of its antecedent physiologic processes. Dr. Paolo Miotti will also address this issue in his later talk on research priorities. The combination of the direct effect of HIV, associated metabolic syndrome, co-infections, and alterations in cellular pathways further disrupt other cellular pathways and the immune system, increasing risk for NCDs in the context of aging. Most organ systems are involved in this morbidity pathway. In order to understand the importance of NCDs in low and middle income settings, we have to better understand what the actual burden of disease is. Unlike in Western settings, though, we face particular challenges in assessing risk factors for diagnosing these conditions. Our data sources are frequently not national or clinical trials registries, but clinic-based cohorts and cross-sectional studies. The key priority remains getting people diagnosed and linked into care and treatment, which you've been hearing quite a lot about at this conference. Getting national programs to dedicate resources to preparing for the future is difficult when the urgencies of today are so compelling. The risk assessment methods that we are most familiar with were developed using Western patient data. So risk indices like Framingham, DAD, VAX, or even basic eGFR calculations may not necessarily fit our populations. It can also be hard to find reliable NCD data in the general population in these settings. And without HIV-negative populations to compare to, it is difficult to separate out what is the result of HIV and ART versus the result of endemic infections or development status. I will touch on just a few NCD risk factors and outcomes for which we have data in low and middle income settings to provide a snapshot of what we know so far. The first is on cardiovascular disease. Reporting for cardiac events like heart attacks and heart failure are generally poor across these settings. Some of our data are from the pre-heart era, which may differ from the post-heart era, and vary by use of specific antiretrovirals, such as protease inhibitors. In a national study in Thailand, metabolic syndrome was seen significantly more frequently in those with a history of ART than naive or HIV-negative individuals. The largest prospective study of primary cardiovascular conditions in Africa was conducted in Soweto, South Africa. Among the 5,300 patients identified with heart conditions, about 10% also had HIV. The most common diagnoses in this subgroup were of cardiomyopathy, pericardial diseases, and valvular problems. Notably, coronary artery disease was infrequent, but this type of study with echocardiography and angiography on this scale is rare. More data have been collected on hypertension, which was recently shown to increase mortality in the AMPATH cohort in Kenya in the absence of advanced HIV disease. This table summarizes some of the available data on hypertension from Africa and Asia. According to the World Health Organization, Africa's hypertension rates are the highest in the world. The top 3 rows are from HIV-positive cohorts, and the bottom 2 rows are from general community-based surveys. Most provide prevalence data of individuals with elevated blood pressures at any time during follow-up or as part of a cross-sectional study. So this is generally a blunt assessment, which is the best I think that we currently have. Of note is a study from Johannesburg on incident hypertension rate after ART initiation, which was lower than the prevalence at baseline. If we are to understand the association between hypertension or other cardiovascular risk factors and their outcomes in aging HIV populations, we will need to better capture serious cardiac events. An NCD for which we do have stronger data on outcomes is cancer. Although some of these cancers are associated with infections, they represent an example of how this type of event monitoring can be feasible in low and middle income countries. This graph from the US CNIX cohort helps affirm that AIDS-related cancers like Kaposi sarcoma and lymphoma are seen earlier in the course of diagnosis and treatment, and that other cancers increase some years afterwards, as seen in the top line. The vast majority of people on ART in the world today are still in the earlier part of this graph. And we are seeing these high rates of Kaposi's and non-Hodgkin's lymphoma in many African countries, as reported in the GlobalCan database of the International Agency for Research on Cancer. On the left side of the graph, the highest incidence and mortality are in 7 African countries, with the US and Australia further down the list. Cohort data provide more details about national and regional outcomes for Kaposi's. All of these studies, except the comparator from CNIX on the bottom, are from the IDEA Global Consortium. These large regional cohorts provide a valuable platform to study these types of uncommon events. In the East Africa study, KS rates stayed high until CD4 levels reached over 350. In Southern Africa, which in this case represents a cohort of primarily Zambian patients, the incidence of KS was 3 to 4 times higher than most common cancers in the general population, like prostate or breast cancer. Better cancer reporting in HIV clinical centers and a parallel focus on cancer surveillance in the general population is allowing this type of analysis of the impact of HIV on cancer outcomes. An NCD we are just beginning to study in low and middle income countries is liver disease. Although a communicable disease, viral hepatitis is the primary precursor to liver failure and hepatocellular carcinoma. We know from Western cohorts that patients with hepatitis C and HIV co-infection have more rapid liver disease progression. The graph on the left is from the U.S. Veterans Administration cohort study, showing higher liver decompensation among those who are co-infected on the top line, even if there has been little documentation of prior liver fibrosis. The French National Hospital database data is on the right, showing on the bottom line that mortality was higher for co-infected patients. This included a significant difference in non-liver and non-AIDS-related mortality. We lack long-term follow-up or hepatitis treatment data on patients in low and middle-income countries, but there are growing efforts to begin studying the prevalence of viral hepatitis and liver disease. The hepatitis B and C co-infection rates vary across low and middle-income countries, with hep C more commonly seen in concentrated epidemics with larger proportions of injecting drug users. The CIDRS cohort in IDEA Southern Africa used the FIB4 and APRI scores to gauge the extent of liver disease in their cohort and found that 8% met criteria for significant fibrosis. In Thailand, a study done by Dr. Anjali, sitting right there, using transient elastography by FibroScan showed that 11% of patients on ART without viral hepatitis had measurable liver stiffness. This cohort had a larger proportion of older patients who had been on ART for much longer periods of time, and the results may be an indication of the future for other countries in the region. A regional study also being conducted through IDEA in 4 countries in Southeast Asia through Treat Asia is assessing treatment eligibility among those with positive hepatitis C antibody tests. Preliminary results show that many of these patients have chronic infection, and almost half have either severe fibrosis or cirrhosis already by FibroScan. There is clearly a great deal of interest in studying liver disease, particularly as new treatments for viral hepatitis are being approved. Although we were only able to touch on a few of the priority NCDs associated with HIV, a common challenge in these settings is the lack of diagnostic capacity and reporting processes that are needed to support reliable surveillance and estimate the burden of NCDs in these populations. Integrating clinical services for chronic diseases with HIV health infrastructure has been tested in pilot studies, but will need to be more fully adapted into public health programs to be sustainable. For the time being, national health surveys, regional cohorts, and cancer registries can help inform the epidemiology of NCDs. If we can include traditional NCD as well as HIV-specific risk factors into these large databases, it would help us to better distinguish the associations between these outcomes and HIV, and then target screening recommendations to those most at risk. I would like to thank Amy Justice, Jentinat Ananwarnit, and Paolo Miotti for their assistance in developing the presentation, and IDEA Southern Africa and the Kirby Institute for their help with the data. Thank you.